conditions that are the consequences of a previous disease or injury. Now, we don't necessarily, we can't necessarily diagnose cirrhosis. That's something that you kind of have to stick a needle in a patient, do a biopsy, and hope that you don't hit various organs such as the lungs, kidneys, or gallbladder. And then you pull it out and you analyze it, and usually that has a pretty fairly good specificity sensitivity to detect whether someone actually has cirrhosis or not. So you can see here that cirrhosis definitely can cause portal hypertension. It can cause esophageal variceal bleeds. It can also lead to ascites, and ascites can eventually also lead to spontaneous bacterial peritonitis. And there could be some hepatic encephalopathy associated with that, as well as, hopefully not, but in the very late stages it can be hepatorenal syndrome. So we're going to talk about each one of those. And I drew this picture here on the next slide to kind of talk about the liver. So to truly understand the disease cirrhosis and portal hypertension, we kind of need to look at the liver and know how it works. So that's kind of like the largest internal organ in the body. It's most complex in the body. It's located underneath the right rib cage. And it's approximately situated to the right side of the stomach. It weighs about maybe 1.2 to 1.6 kilograms in healthy adults. And you can see here there's a right lobe and a left lobe. And you can see the gallbladder underneath. And then we know that the gallbladder stores bile for secretion into the small intestine. That's a picture of the falciform ligament. And these are kind of like coronary ligaments. They're sort of that part of that peritoneal reflection that holds the liver to the inferior surface of the diaphragm. So we know altogether here that the liver has three primary essential functions, right? Everyone agrees? There's bile formation, glucose metabolism. The liver converts glucose to glycogen. It stores it in the hepatocytes. Subsequently, the glycogen is converted back to glucose and released as needed into the bloodstream to sort of maintain normal levels of blood glucose. And it can also synthesize additional glucose via a process called gluconeogenesis. When it comes to ammonia conversion, that's sort of like that third essential function. The gluconeogenesis results in the formation of ammonia as a byproduct. So ammonia is very toxic to the liver and to the body also. So the liver has to try to remove it from the blood supply very quickly and convert it to urea, which is excreted in the kidney. So we know that the liver is a very important organ. And the return of the blood to the heart has basically two systems. There's the portal venous system. That's one of the questions that I asked you. That's mainly the blood entering the liver, coming back from the intestine, stomach, and spleen. And then there's a systemic caval system. That's blood coming back to the heart, i.e. via the superior vena cava, inferior vena cava, cava. Now, on the IRAD, there was a question that asked specifically, the liver is supplied by blood supply known as the hepatic artery, dual blood supply portal vein, or dual blood supply hepatic vein portal artery, or dual blood supply portal artery. So we're going to see what the class chose, primarily what they thought it was, and I'm going to put that up on the screen there, so you can see that the majority of the class chose the answer B. They said the liver is supplied by dual blood supply, portal vein and hepatic artery. So I think the majority of you guys agreed to that. Let's see if we are correct on that assessment. So, the dual blood supply to the liver. Let's look at that a little bit more carefully. Portal vein, I drew that down there, and reflective of a blue deoxygenated state. That's it has like a left and right portal vein, sort of like feeds into the liver. And we talked about it earlier how it delivers approximately 75% of the blood volume or supply to the liver. It delivers primarily deoxygenated blood returning from the small intestine, large intestine, stomach, spleen. And this blood contains a lot of nutrients. Now you can see the direction of the arrow there, how the blood's going up in that direction. And then on the right there, you can see the aorta. It's a very important vessel that comes from the heart. And it's also in the abdominal section. So the left and right hepatic artery, it kind of branches off and delivers about 25% of blood volume or supply to the liver. And it delivers oxygenated, meaning it probably lacks nutrients. unlike the portal vein that has a lot of nutrients. So basically this is blood from the general circulation that comes into the liver. So we see that's a dual blood supply. So left and hepatic, approximately 25% of blood supply to the liver, and the liver's oxygenated blood from the general circulation. And you can see here there's 3 large veins which drains the hepatic parenchyma into the inferior vena cava. It comes off of the, kind of like if you think of it on the top of the liver. It's called the left hepatic vein, middle hepatic vein, right hepatic vein. So it's kind of nice to know these names. That way you can kind of reference it. And you can see there the vena cava. I kind of illustrate that. By the way, I drew these pictures myself as you're looking on the slides from Canvas. So it's just my illustration. So you guys were correct. Answer B is the correct option. So good job for the teams that selected that answer. You'll also see this depiction of the portal venous system in your chapter 24 reading that comes from Access Pharmacy. So let's talk about venous blood return from the stomach. Also very important. We can see that veins are coming from almost every part of the digestive tract. Even the lower esophagus, it kind of converges to form the hepatic portal veins that enters the liver. You probably have things here like esophageal veins, left gastric vein, right gastric vein, short gastric vein, left gastromental veins, right gastromental veins. So there's a lot of veins that sort of feed, return blood from the stomach. Now, if I look at the intestine, you can see the large and the small. You can kind of see that veins from several organs, including the intestines, pancreas, even the stomach, spleen, they kind of drain into the hepatic portal vein. And these can be anything like the inferior mesenteric veins, superior mesenteric veins, the left colic vein, or the middle colic vein, or the right colic vein, or the ileocolic vein, or the rectum. There's just a sigmoid and rectosigmoid vein. So there's a lot of veins, and I just named a few, but these veins are really important because they all form what's known to be as a tributary. Now, here's a picture of what I would depict. Now, don't get that confused. It's not a kidney, it's a spleen. So I'm going to illustrate why that's important, why I'm drawing it there. But you can see the splenic vein feeding back into the portal vein. And all together, now you don't need to memorize the names of the veins that I told you. They're not even really testable at this point. This is just a concept, but the main point is that this is a tributary. And a tributary is basically a river or a bunch of streams of a bunch of smaller things coming into one larger river or lake. If I had to include more veins, I'll probably say like the appendicular vein or the posterior cecal veins or the posterior anterior cecal veins or the anterior inferior pancreoduodenal veins or the posterior inferior pancreoduodenal veins or the anterior superior. So there's a lot of veins and they're all tributaries and they're all coming together forming that very important portal vein. So we can see how important the portal vein is in the human body. So we call these the tributaries that are forming one big pull that's feeding back into the liver. Now, if I go to question number 2, the liver portal triad consists of the following. Let's go back again to see what the class chose. The class had chosen, in their assessment, they thought it was clearly a unanimous decision there. So, let's see if you guys are correct. I'm going to go back to the slide. So let's look at the hepatic lobules. I'm going to kind of zone in and take a magnification of a single hepatic lobule. So this is the fun part. So I'm going to magnify a very tiny area of the liver. I'm going to take that little window there, and then I'm going to kind of show you approximately that there are probably about 50,000, maybe 100,000 hepatic lobules in the liver that make up the liver. And these lobules are kind of like functional units of the liver. They're organized in these cylindrical structures. And each lobule contains many types of hepatic cells. So I would call it as a hexagonal shape known as a lobular. Each lobule contains about many types of hepatic cell. So I kind of drew that myself to kind of illustrate what I think it is, the shape of a bipyramidal hexagonal prism. And then I know there's like, you can reference it 1, 2, 3 based on the 6 sides. And then if I take that lobule and I take a cross-sectional view of that lobule, liver lobule, roughly hexagonal in cross-section, I kind of cut it down. I'm going to notice that there's this, in the center there, you see that blue deoxygenated for color. In the center of the lobule lies that central vein, which collects blood from the lobule and carries it to the hepatic veins. So this central vein kind of unites to form larger sublobular veins, which ultimately join hepatic veins. And blood flows to the heart via the inferior vena cava, right? Once it exits. So, now let's take a look at this organization of the portal triads within a hepatic lobule. So I'm going to take back that structure again. And here you're going to see sort of like the red representing hepatic arteries. You're going to see the blue or purple representing like a portal vein. It's sort of superimposed on the red. And then now we superimpose the green, and these are like bile ducts. So together they form that portal triad. So if I took that lobule and I gave a transverse plane cross, I cut it from the kind of like a transverse plane. Now I'm going to look at it from the top. Now I'm going to look at a transverse view. I'm going to see an imaginary line. I'm going to sort of like make my own line here. I'm just kind of like completing that shape. And it's going to be a line connecting 6 portal triads, which represents the outer borders of a hepatic lobule. So I'm looking at it down and taking that transverse cross-sectional view. Now, of course, the liver is made of nearly 100,000 of these. So you can see that, obviously, it's a lot. And there's a picture of it in your chapter reading, the legend called the hepatic lobule. You'll see that in your reading as well. Now, if I take a bunch of those structures and I put it together, I'm going to try to identify what's called the liver acinus. It's kind of like another way to view the structure. This can be seen a lot of times on histological preparation. So this model is kind of important for understanding liver physiology and pathology. So the liver acinus is going to kind of focus on function. Now, so remember that central vein I showed you earlier, that blue line? It sort of unites to form that larger sublobular veins, which ultimately joins hepatic veins. So it's kind of like the blood flow to the heart via the inferior vena cava. So you can kind of see the central vein there. And then you can kind of see the red there kind of represents the hepatic artery, and we add the sort of like that portal vein system and the bile. So now we're going to identify what we think is, or we believe is to be a part of the liver acinus. It's sort of like that diamond shape, that yellow area, kind of involves approximately 2 portal triads and 2 central veins. So to identify the acinus, you want to take the short axis, so the 2 portal triads, and then you want to take the long axis, 2 central veins, and you kind of want to draw that yellow. And you can, of course, replicate that in various sections. So this model is really important because it emphasizes the metabolic differences in the hepatocytes between the portal triads and the central veins. So we can think of it as the cells of the acinus. They're sort of divided into 3 zones. You'll see that in your reading. They're kind of numbered in the direction of the blood flow from 1 to 3. So you can see kind of 1, blood sort of flows past the hepatocytes in zone 1, then zone 2 kind of goes to zone 2 there. Zone 1. You can kind of see zone 1. So then it'll go to zone 2, finally to zone 3 before entering the central vein. So hepatocytes in zone 1, they kind of lie along the short axis between the portal triads. So these cells are kind of like the first to receive everything in the blood circulating, including oxygen, absorb nutrients, and absorb xenobiotics. Zone 1, they say, you can see that in your reading, that it's involved in gluconeogenesis, so the generation of glucose and the urea synthesis and oxidative metabolism. And then zone 2, you can see that it has every characteristics intermediate between zones 1 and 3. And then you can see that in zone 3, that these are hepatocytes. They're closest to the central vein, and they're therefore the last to receive incoming blood. They're hepatocytes. They carry out the functions of glycolysis. They convert glucose into pyruvate. And then lipogenesis, that's a process by which acetyl-CoA is converted to fatty acids. So you can kind of see that as blood moves towards the central veins, it becomes depleted of oxygen, nutrients, and xenobiotics. So it's very important. So if I look at the center of the hepatic lobule once again to the central vein, I'm going to see that it connects the hepatic vein, which leaves the liver, towards the heart. And there's that central vein. These are structures that we identified earlier: portal vein, hepatic artery, and bile duct. So they're going to be comprised of the portal triad. So these are 6 ports, 6 per hepatic lobules. Now, question number 2 asks specifically the question, and you guys had all answered it correctly as a team, so good job. So the liver portal triad consists of the branches of the portal vein, hepatic artery, and the bile duct. So if I continue in this classic hepatic lobule, we're going to look at how blood flows from the portal triads to the central vein, and that's depicted by the arrow direction. And you can kind of see here how bile is produced in the hepatocytes. It kind of flows in the opposite direction from the central position towards the portal triads of the lobule periphery. And here is a depiction of liver sinusoids. And you can kind of see if I magnify this area here of the liver sinusoid, I'm going to get these hepatic macrophages. And within that, it's going to have like Kupffer cells, important in the immune system. There's a central vein. There's portal triad, hepatocytes, sinusoids, bile caniculi, and the Kupffer cells. So, hepatic macrophages, Kupffer cells, they're important in the immune system, as I mentioned. So as blood sort of travels through the liver, the cells called Kupffer cells, they remove the waste products such as bacteria, old and defective blood cells, and other foreign materials. So the breakdown of the defective blood cells results in the formation of a pigment called bilirubin. And then the hepatocytes remove bilirubin from the blood and modify it so it can be secreted into adjacent small bile. That's called the bile caniculi. So in intrahepatic diseases, you're going to have a disruption of that flow of bile through the liver, causing cholestasis. So a stoppage or slowing of the bile flow from the biliary cirrhosis. And at this point, the bile is going to be unable to drain from the hepatocytes and enter the bile ductal system to drain the duodenum. So the liver attempts to repair itself by kind of forming new bile routes. So what happens? Well, basically, when you try to accommodate the drainage, the liver kind of becomes enlarged. It might even have this green hue color. And of course, it gets darker, and it continues to be, the flow continues to be impeded. The liver takes on this green hue, and it can build up. And eventually, yes, you can end up with cirrhosis. So you might see this type of inflammation and scarring of small intrahepatic biliary ducts in primary biliary cirrhosis, and this leads to destruction of liver tissue, so it's not a good thing. So once we get to cirrhosis, that's pretty much the end stage of chronic liver disease, unfortunately, when there's not going to be much functioning liver left. You know, the tissues have to kind of be replaced by fibrous tissue. So you can kind of see how important it is to understand this. Now, let's go to question 5. We're not necessarily going in any particular order, but we're trying to address 8 of the 10 questions in the IRAD this morning. So, a major treatment goal in the therapy of portal hypertension. Let's see what you guys thought was the correct answer. So we're going to go back to the class's decision on that. And we could kind of see, we can kind of see that, again, the class felt it was unanimously the prevention of bleeding. So I would say good job. But we'll go back to our slide point there. Prevention of bleeding. So let's look at the liver. So I'm going to kind of try to illustrate portal hypertension by using liver cirrhosis as a cause, because we know that in cirrhosis is can cause portal hypertension. It's probably one of the leading causes of portal hypertension. So here is you notice that nodule that I depicted on the surface of the liver. I drew that green there to try to illustrate cirrhosis. And I kind of shrunk the picture a little bit because in cirrhosis we know that the liver kind of shrinks a little bit in size, and it results in those fibrotic changes involving hepatic sinusoids. The fibrosis of those hepatic parenchyma kind of results in altered hepatic function, restricted venous flow, outflow, portal hypertension, poor systemic shunting. Advanced fibrosis of cirrhosis can also lead to shunting of the portal and arterial blood supply. Kind of like that overall state results in sort of like this vasodilated state, which is not good. And then once you get that activation of the renin-angiotensin system, aldosterone system, and altered hepatic synthetic function. So this is all not good because of cirrhosis. So we're going to kind of look at portal hypertension, some hallmark pathophysiology, sequelae of cirrhosis. So when I think about portal hypertension, I don't really think of it as a disease in and of itself. It's more like a physiologic state. So in other words, it's not necessarily the portal vein that's disease, it's something that's causing it. And we know that it's an area where there's excessively high pressure in the portal vein. It kind of develops when resistance to blood flow into or through the liver is increased because of that fibrosis and scarring of the liver. Cirrhosis, it can kind of begin to back up blood, leading to venous dilations in the esophagus and the legs and the rectum. And at the same time, the blood pressure increases in the portal venous system. Blood that normally enters the liver via the portal vein, it kind of begins to bypass the liver, depriving those hepatocytes of their ability to perform like those essential functions that you need. And when you activate those vasodilatory mechanisms, they're kind of mediated mostly by nitric oxide overproduction. So it leads to a lot of splanchnic and peripheral arterial vasodilation in those advanced disease, and you get a drop in the arterial pressure. So we know this is a lot of bad things that happen because of that. So I can think of portal hypertension being primarily due to three causes that can be sort of divided. There's prehepatic causes. That's probably relatively rare. And then there's going to be things like maybe some decreased responsiveness to vasoconstrictors, formation of new blood vessels as a result of that. So how many of you guys have heard of things such as congenital atresias, or the portal vein in children where the vein is not formed appropriately when it's kinked or something? This can lead to a prehepatic cause of portal hypertension. When we think about external compressions, there might be examples like such as a Wilms tumor, or maybe a thrombosis, or a portal vein thrombosis, or splenic vein thrombosis that can kind of block this area. Now, if I put the line there, I'm sort of depicting by far the most common form of intrahepatic cause of portal hypertension. That's probably maybe 85% of all portal hypertension. It's caused by that sort of like that cirrhosis, that most common pathologic diagnosis that has to be made. And alcoholics, most common, chronic hepatitis A, B, and C, autoimmune hepatitis, primary biliary cirrhosis, primary sclerosing cholangitis, non-alcoholics, steatohepatitis, biliary atresia, cryptogenic or schistosomiasis is kind of occurs around the world. So these are things that can cause intrahepatic causes of portal hypertension. Now, I can also block the exit or the drainage in portal to cause portal hypertension. So we kind of think of this one being probably relatively rare. How many of you guys have heard of like Budd-Chiari syndrome? Sometimes you probably hear that diagnosis, that thrombosis of the compression of the hepatic vein that's draining the liver. There's like primary and secondary Budd-Chiari. Pregnancy sometimes can cause this. So when you get a patient with portal hypertension, and later on we'll talk about the hepatic encephalopathy that can result as well as that, you can actually smell a patient's breath because it's that bad. You get that sort of like sweet smell or musty smell, and some people call it the breath of the dead because it's known as hepatic phenohepaticus. It's kind of like a condition seen in portal hypertension where you get that poor systemic shunting, kind of allows thiol to pass directly into the lungs. So you get that awful smell. So it's one way to tell. So let's look at this question. We had asked the least likely presenting sample of a patient with liver cirrhosis. And I believe that you guys unanimously chose, I saw it earlier, you guys unanimously chose the correct answer. So I'm going to go to that result there and see that the overall response there was pretty good. Whoops. So there it is right there. So let's go back to the slides. So let's look at this, the spleen. Now, here's the spleen, and what just happened? What just happened here? Can someone just tell me what just happened? I got congestion, right? In portal hypertension. All of a sudden you get that congestion of the veins going into the spleen, and it occurs as a direct result of increased venous pressure. Now, if I had a blockage in that splenic vein, later on I'm going to talk about ascites, but I may not necessarily get the ascites because I'm not actually blocking at the portal vein, but I'm blocking before it. So that's why that spleen enlarges. So you may not get an ascites function, which I'll talk about. So good job, again, class. The late likely presenting sequelae of a patient with liver cirrhosis is hypothyroidism. Remember in A, who can think of why A is incorrect? What makes A wrong? Anybody? Gynecomastia can happen in males and females. Now the liver is responsible for breaking down that estrogen. So if it's not functioning well, you get elevated estrogen levels, and that can result. And of course, I just showed you a picture of splenomegaly. And then the hepatopulmonary syndrome, that's important. Now, when I think about portal hypertension due to some form of blockage of the portal vein, causing conditions like ascites, where I'm getting that sort of like increase on cardiac pressure and fluids being transferred to the peritoneal space. I'm thinking of things like people with right-sided heart failure, and you get that increased pressure buildup in the pulmonary veins, pulmonary artery, and it causes a sort of like a pulmonary congestion edema. So it's, to me, it's kind of analogous. So if that helps you, definitely use that analogy. So now this question here, formation of enlarged collateral veins in the venous walls of the lower part of the esophagus that may bleed or hemorrhage are known as. So you guys, let's take a look at your response for number 6 to see how you did. And so I think, again, very good. The majority of the class did choose the right answer once again. So we'll go through that. So a varix is singular, varices are plural. And asterixis, we'll talk about that in a little bit when we go into some of the other sequelae, but that's mainly a flapping hand tremor. Red whale marks. You guys have heard of that? You guys read about that in your chapter, right? So these are risk factors that are kind of used, or you can say the child Pew class C, which we'll talk about later. But they're basically there to kind of assess and determine if the patients with small varices should receive prophylactic therapy with non-selective beta-adrenergic blockers to prevent variceal hemorrhage. So, how many of you guys think it's A? How many of you guys think it's B? Anybody think it's, how many of you guys think the answer is B? Or C? Or D? No one thinks it's any of these? I'll tell you what, on the next question, I'm going to ask all the teams to hold up their cards to put them up before we show the answer. How's that? And we're going to do it simultaneously. We're going to use those cards in front of us. So, but let's go through this right now and come up with the answer. When I think of bleeding varices, I'm going to draw the liver, maybe the stomach. So a lot of times patients, they're going to first present with to the hospital with a sort of like an upper GI bleed, and you don't really know what it is at that time, whether it's a peptic ulcer bleed or any kind of esophageal bleed. It could be any one of those. And you're going to perform, the doctor's going to perform an upper endoscopy or fibroctomy tube, commonly referred to as EGD, that's esophagogastroduodenoscopy. And they might find on EGD like small, several, medium, or large esophageal varices. Now, it doesn't necessarily mean that they're necessarily bleeding, but they could have been. But for every patient with new diagnosis of cirrhosis, they should sort of have that EGD to look for the presence and sizes of these varices. So esophageal varices, I think of them as very tortuous collateral vessels. They kind of form secondary to increased resistance of blood flow within the liver between the portal and systemic circulation. And when you sort of get that portal pressure gradient difference between the portal vein pressure and the hepatic vein pressure, you kind of get that increase about the thresholds. Those tortuous collateral blood vessels, they start to develop at the site of this communication between the portal and systemic circulation. And that whole process that you see is kind of modulated by angiogenic factors. So you're going to get that formation of the portal systemic collaterals, those veins, those venous inflow is going to increase to those areas. It's going to result in those splenic vasodilatations increase and try to increase blood supply, sort of like try to find new routes. So very dangerous, life-threatening. And so I think of these as a very important collaterals to address, because if they're starting to form, the blood can't go through the portal vein into the liver where it needs to be processed. It starts to form these incredible pressure collaterals. Lots of flows will go through them, and eventually they might rupture and cause massive hematemesis, where you get that vomiting of blood. The patient becomes fatigued. They become dizzy. They start presenting with black tarry stools because your body is breaking down red blood cells. So lots of different things that can happen. And that's why when they're looking down through the endoscopy, they're looking for those red whale markings. And they're trying to see those risk points. whether the patient's going to hemorrhage or not. So now this is going to be sort of like varices that can occur along various places, including the esophagus, stomach, and rectum. So you can kind of see this is kind of like a different area. You can kind of see there's more on the intestine. There's a left and right superior rectal vein, middle rectal vein, or velar rectal vein. And I can get the same kind of thing happening down at the humeral plexus vein. You do a rectal exam, you see dilated rectal veins, those are hemorrhoids. So you can kind of see that these varices can occur in all those places. So, if you guys thought the answer was A, which you did, you guys got it correct. Formation of enlarged collateral veins in the walls of the lower part of the esophagus that may lead to bleeding or hemorrhage are known as varices. And then, that other question that I had asked about, question 5, a major treatment goal in the therapy of portal hypertension. So I'm going to ask you to raise your cards because I do want audience participation. So at the same time, I'm going to read off the answers to that. So a major treatment goal in the treatment of the therapy of portal hypertension. Is it A, reduce alcohol intake? Is it B, prevention of bleeding? Is it C, maintaining systolic or diastolic blood pressure at 130/80? Or the use of proton pump inhibitor? So on the count of 3, everyone raise your cards, 1, 2, or 3, A, B, or C. So 1, 2, 3. All right, so very good. It looks like you guys got that correct. Prevention of bleeding is the correct answer. So I wanted to make sure you guys participate in that one, so thank you very much for that participation. So now I'm going to ask you the other question on the IRAT. All the following clinical presentations are suspected to be as a result of hormone imbalance in male patients with liver cirrhosis, except. So on the count of 3, I'm going to ask you, is it A, B, or C, or D? So everyone ready? 1, please use your cards. 2, 3. All right. So it looks like the majority of you answered pretty well there. Let's look at that a little bit. We got probably maybe a depiction of a normal person here who has abdomen. And in portal hypertension, you might get it might involve the para-umbilical veins, and you get sort of like this Medusa mythological figure. You guys have heard of her, sort of like that head with the snakes coming out of it. So it's the swollen subcutaneous veins on the surface of the abdomen. It kind of radiates out from the umbilicus. It kind of results from portal hypertension in the umbilical area of the vein that's present to subcutaneous areas of the abdomen. So I could probably draw it this way, or I could probably draw it that way. The idea is that there are these blue tortuous veins. Now let's look at the hands now, because earlier I talked about estrogen, how the liver is responsible for breaking down that estrogen. But if the liver's not working, I might get this from your chapter again, pulmonary erythema. You see that red hand, where you can ask somebody to show me your hands because you suspect they might have some kind of liver condition. And this is alcoholic cirrhosis. People may have that. If they show your hands, it might be palmar, it might be red on the central pallor side. So now I can also ask you to look for other diagnostic, or perhaps not necessarily diagnostic, but other clues, and it involves skin manifestation as well. It's another one called spider angiomata, and this is sort of like that. Looks like that area of the skin that has a spider growing out of it. You might see that in hepatitis C maybe, or any type of advanced liver diseases that can occur as well. So you guys got that correct. That question that you answered on the IRAT, caput medusae, would have been the exception. So another one of the audience participation again for this one is on question number 9 on the IRAT. So the question asks about advanced liver disease patients with cirrhosis who fail conventional therapy to tamponade blood flow of bleeding varices due to portal hypertension may be considered. Who can tell me what I mean by tamponade blood flow? Does anybody want to share what they know what that means? When we tamponade the blood flow, we're maybe inserting a device in there, maybe a balloon, inflating it, and we're covering up that bleeding spot to try to put pressure on there to prevent it from bleeding. So on the count of 3, if you can please tell me if it's A, the Child-Pugh, the MELD, the TIPS, or the SAG. So on a count of 3, please use your audience response card, 1, 2, and 3. All right, very good. And I saw that you guys had answered that well on the IRAT as a unanimous decision as well. So, well, let's go over it. When we have primarily sort of like salvage therapy, maybe at the point where we kind of really need to do something, or the physician needs to do something because they can't stop the bleeding, or a patient keeps coming back with more bleeding episodes. They might think about doing hepatic shunts. So we're diverting blood away from the liver. So it's going to require some kind of open surgical procedure where you're going to connect the portal vein directly to the inferior vena cava, perhaps. That's just one way. In cases of like variceal bleeding where it's uncontrolled by pharmacologic and endoscopic therapy, we're going to probably do a thing called TIPS. That's probably going to be the most effective option. It's an option probably in patients who are going to be experiencing those recurrent variceal hemorrhages despite combination pharmacologic and endoscopic therapy, which we're going to go over. And this is kind of like a radiologically guided procedure where you go into a patient. It's generally done by an interventional radiologist. It may be the third line of your endoscopic procedures. If it doesn't work, perhaps balloon tamponade didn't work. So now they're going to start thinking about transjugular intrahepatic port systemic shunt. So it kind of involves inserting that catheter into the jugular vein, and then it sort of threads through the superior and inferior vena cava, and through the diaphragm it kind of reaches the hepatic tributary within the liver. And it's kind of considered one of the more modern approaches and less invasive than open surgery, where you open up an entire patient. So it's that guide wire. From here, you kind of make that channel. You kind of see that channel that's being made through the parenchyma of the liver. It kind of reaches a branch of the portal vein within the liver, and stent is then inserted to maintain a communication channel between the portal venous system and the systemic hepatic vein. So you can kind of see that you can achieve this by inserting sort of like this percutaneously through placements of transjugular intrahepatic for systemic shunt or surgically. And then you're going to kind of feed this meshwork of shunt that connects the hypertensive portal system and the low pressure systemic veins to kind of reverse that portal hypertension. So now you have this connection here. So you inflate your shunt, you remove that catheter. So this may be good. You're definitely bypassing the liver now, but the problem is now that the liver is not processing and slowing down the blood flow that it normally did. So obviously it can lead to other problems. There could be shunt stenosis or thrombosis or stent failures. Bypassing the liver so quickly, it's so dangerous because you can even encourage some of that post-operative encephalopathy. There are contraindications to this procedure, like somebody with severe encephalopathy or polycystic liver disease, or if they have like right heart failure. Can you imagine someone with a right heart failure where the blood is returning from the inferior vena cava going back into the right atrium, and you get all of a sudden that surge of blood flow into the right atrium? That blood supply is so strong. And if you have already a condition of right-sided heart failure, and you already have that pulmonary congestion, and you have this massive supply of blood, now you're going to get even more fulminant degeneration of the patient of their right-sided heart failure, and you're just going to get a lot worse. So think about the complications and the contraindications. And there's a picture right there in your text of a shunt that's been inflated that connects that top portion to the bottom portion, right? The hepatic vein to the portal vein. That's the idea behind it. So I'm going to show you again the answer to that question that you guys answered, and the majority of you did get that. So good job on understanding that salvage therapy, or whether it's some type of shunt surgery, or whether there's some type of transjugular intrahepatic port systemic shunt. So that procedure is really important. Now let's go over this last question, and then we're going to take a break. So which of the following statement is false? Audience response at a count of 3. 1, 2, 3. I'm sorry, I should have given you time to read that. But I do see that it looks like the majority of you did get that correct. So let's just go over that table. Child-Turcotte-Pugh, that's a classification of severe liver disease. It sort of yields that scoring system that helps clinicians grade disease severity and predict long-term risks and mortality. Like Class A is probably milder. Class C, you're probably not going to live much if they say that. Maybe it could, for example, like 3 years, whereas Class A maybe 20 years, for example. But Class C is a lot worse. There's main limitations of this. It sort of uses subjectives such as ascites and hepatic encephalopathy, which are subject to clinical interpretation and may be altered by therapy. And this scoring system is often used to recommend drug dosing adjustments for patients with liver failure when available to assess and define the severity of liver cirrhosis. So you don't need to memorize this. I'm not testing you on these details. The idea is that you guys know it's out there. And then, of course, the MELD is an equation here. Parameters included in the MELD might be like serum creatinine, bilirubin, INR, sort of like based on the patient's risk of dying while waiting for a liver transplant. Survivability model of a patient with end-stage liver disease. So it's also a scoring system, and don't worry about memorizing it. So very good on that participation. B is the correct answer. So A, C, and D are all correct on that IRAC question. And then here I'm just going to show you with the last slide on the UNOS, the network of sharing or network for organ sharing. It's sort of like a high MELD score, sort of strongly associated with early pre-implantation, waitlist, mortality. So therefore, patients with the highest MELD score are given priority by UNOS in terms of organ allocation. The only exception is that status 1, where patients are given the highest priority. So with that in mind, let's go ahead and take that 15-minute break, and we'll come back and do another activity. So thank you.